Welcome back to the Deep Dive, where we turn complex info into, well, clear insights. Ever feel like medical jargon is just
Yeah.
another language? You want to be really informed, but wow, the sheer amount of stuff out there. Think of us as your guides, yeah,
Yeah.
cutting through that noise. Today, we're jumping into renal pharmacology, basically the key meds for kidney health, fluid balance, things that, affect the whole body. Our mission, shortcut to really getting it. We've pulled the absolute essentials from a clinical review, renal pharmacology, and therapeutics. So you'll understand not just what these drugs do, but the how, the why, and crucially, the precautions.
And it's fascinating, isn't it, how interconnected it all is. These meds really highlight the kidney's role beyond just filtering waste. It's a master regulator. Fluids, electrolytes, hormones will look for those patterns, those connections to make it stick.
Exactly. So prepping for a meeting, getting up to speed, or just curious, get ready for some aha moments. Let's dive in. Okay, first up, diuretics. The heavy hitters for fluid management. People call them water pills, but that barely scratches the surface. Let's start with furosemide. Lots of people know that name. Why is it such a powerful tool?
Well, the key is its mechanism. It's a loop diuretic. It works right in the loop of renal, a specific part of the kidney's filtering tubes, its main job, to block this thing called the narcotic Think of it like shutting down a major pump that pulls salt and water back into the bottle.
Okay, so if that pump's offline,
Okay.
what happens next? What are the ripple effects?
You get this big increase in excretion, not just sodium and water, but chloride, potassium, calcium, magnesium, too. It's potent, very potent, means it can pull off fluid really fast.
And when would you need that kind of power?
It's really a go-to for fluid overload. Think edema, swelling, and CKD, nephrotic syndrome, heart failure, especially acute pulmonary edema fluid in the lungs. Furosemide gives rapid relief there. Life-saving sometimes. It can even help lower high calcium levels, often with IV fluids. And maybe symptomatically an acute kidney injury to keep urine flowing, though importantly it doesn't cure the AKI itself.
Right. But with that much power, there have got to be serious side effects, precautions. What's the main thing to watch for?
Absolutely. The biggest risk is messing up electrolytes. We worry about hypokalemia, low potassium, hyponatremia, low sodium, hypocalcemia, hypermagnesemia. Low potassium, hypokalemia, that's particularly dangerous, can cause heart rhythm problems or arrhythmias, and makes digoxin toxicity worse. You can also get metabolic alkalosis, an acid-base imbalance from losing chloride and potassium. And of course, too much fluid loss leads to hypovolemia, low blood pressure, dehydration.
And what about that specific concern about hearing? That seems unusual.
Odor toxicity. Yes, that's a known risk. Less common, but real, especially with fast IV pushes or if you combine it with other drugs toxic to the ear, like aminoglycoside antibiotics. So, a key clinical pearl for you: always give IV furosemide slowly, like over at least a minute or two, reduces that risk. And monitoring. We watch fluid in, fluid out, daily weight, blood pressure, and definitely electrolytes, Kna, MgK, creatinine. Expect metabolic alkalosis if you overdo the diuresis.
Okay, let's switch gears. Spironolactone. Another diuretic, but with a totally different reputation, right? More potassium-focused.
Exactly. Spironolactone is different. It's a potassium-sparing diuretic and an aldosterone antagonist. Its mechanism is distinct. It blocks receptors for aldosterone, a hormone down in the collecting duct, the last part of the kidney filter. Aldosterone usually tells the body, keep sodium and water, ditch potassium. Spironolactone says, nope, blocks that message.
So instead of losing potassium, like with furosemide, this one actually helps you keep it.
Okay.
That's clever.
Precisely. You lose sodium and water, but you hold on to potassium and hydrogen ions. It's generally weaker for just pure fluid removal compared to loops, but its value in counteracting potassium loss and its hormonal effects is huge.
So where does it really fit in clinically?
Often used for resistant hypertension, especially if someone has CKD. It's also first line for cirrhotic ascites, that fluid buildup in the belly from liver disease. And in heart failure, it's known to actually improve survival, not just fluid removal, but blocking those damaging neurohormonal effects. But you have to be careful, really careful in late-stage CKD or ESRD, because the risk of high potassium is significant.
And that risk, hyperkalemia, too much potassium, that's the main downside.
Yes, that's the big one, hyperkalemia. Especially in CKD, or if patients are also on ACE inhibitors, ARBs, or potassium supplements. It can also cause metabolic acidosis because it holds on to hydrogen ions. And uniquely, because it affects androgen receptors, it can cause endocrine side effects: gynecomastia in men, impotence, menstrual issues, breast tenderness.
So potassium balance is the tightrope here. I've heard they sometimes use furosemide and spironolactone together. Seems counterintuitive, but what's the logic?
Yeah, it's a great example of using drugs together smartly. Combining spironolactone with a loop diuretic like furosemide, say in CKD or heart failure, is really common. Furosemide pulls off fluid but wastes potassium. Spironolactone helps hold on to that potassium, adds a bit more diuresis, and blocks aldosterone. It gives you a much more balanced approach to getting fluid off without tanking the potassium. But it's a no-go if potassium is already high, say over 5.0, or if kidney function, the eGFR, is below 30. The risk of hyperkalemia just gets too high then.
Fascinating. They really complement each other. Okay, quick touch on a third type, mannitol. Very different beast, this one.
Very different. Mannitol is an osmotic diuretic. Its mechanism is cool. It's basically an inert sugar that gets filtered by the kidney but not reabsorbed. So as it goes through the kidney tubules, it acts like a sponge, osmotically pulling water with it, increases urine flow significantly, and crucially, it also temporarily pulls water out of cells and into the bloodstream and spaces around cells.
Ah, so it's not just about total body fluid, but shifting fluid between compartments within the body.
Exactly. Its main jobs are things like rapidly lowering high pressure inside the skull intracranial pressure or inside the eye intraocular pressure, like in acute glaucoma. It might also be used sometimes to help prevent acute kidney injury in specific situations like rhabdomyolysis, muscle breakdown, to flush things out.
But shifting fluids like that sounds potentially risky. Huge precautions, I imagine.
Oh, absolutely critical. Mannitol is contraindicated a definite no if someone isn't making urine, anuria, or if they have severe decompensated heart failure. Why? Because those fluid shifts can overload the heart and lungs, worsening pulmonary edema. Also generally avoided in active brain bleeds unless maybe during brain surgery itself. Monitoring is intense. Volume status, listening to the lungs, checking serum osmolality, basically how concentrated the blood is. You stop it if osmolality climbs over 320 or if you see signs of pulmonary edema. Powerful, but needs respect.
Okay, changing direction a bit, let's talk systemically. Kidney problems often impact bones, minerals, conditions like hyperphosphatemia.
Yes, this is a huge part of CKD management. As kidneys fail, they can't get rid of phosphate properly. It builds up hyperphosphatemia that triggers a whole cascade, including problems with parathyroid hormone, bone disease, so phosphate binders are essential.
Phosphate binders, how do they actually work and what are the options?
The mechanism is pretty neat, actually. You take them with food. They basically grab onto the phosphate from your meal right there in your gut, form these insoluble clumps, and these clumps just pass right through you in the stool. Phosphate never gets absorbed. Simple, but effective. We have calcium-based ones, calcium acetate, calcium carbonate, and non-calcium ones like sevelamer, lanthanum, and some newer iron-based binders too.
And the choice matters, presumably. Calcium versus non-calcium.
It really does. Calcium binders work, but they can raise calcium levels hypercalcemia and might contribute to vascular calcification, hardening of arteries. Not ideal. So if a patient already has high calcium or lots of calcification, we prefer the non-calcium options. Side effects are mostly GI stuff, upset stomach, constipation. And the key thing to remember, take them with meals. That's when the dietary phosphate is there to be bound. Also need to separate them from other meds like levothyroxine or some antibiotics as they can block their absorption.
Got it. And vitamin D often comes up in this same conversation about minerals, right?
Absolutely. Vitamin D is crucial for calcium and phosphate balance. There's nutritional D like D3, cholecalciferol or D2, ergocalciferol, used for deficiency, often in earlier CKD. But then there are the active forms or analogs, calcitrol, paracalcitol, doxorcalciferol. These are different.
Different how? What's the key difference in what they do?
Well, both types help absorb calcium and phosphate from your food, but the active forms have an extra, very important job. They directly tell the parathyroid gland to calm down, suppressing PTH levels. That's vital for managing secondary hyperparathyroidism, a major complication in CKD, especially on dialysis.
Okay, so what do we need to watch out for when using these, the potential downsides?
The main risks are pushing calcium or phosphate levels too high. Hypercalcemia, hyperphosphatemia, that can worsen calcification, cause itching pruritus. So monitoring is key. Checking calcium, phosphate, PTH levels regularly, like every 4 to 12 weeks after a dose change. And you hold the drug if those levels creep up too much.
Okay, let's pivot again. Anemia,
Mm.
very common in kidney disease. There's a specific treatment involving erythropoietin.
Spot on. Anemia of CKD is almost universal. The treatment involves ESA's erythropoiesis-stimulating agents, like aepoetin alpha or the longer-acting darbepoetin alpha. Their mechanism. They're basically lab-made versions of erythropoietin, the hormone kidneys normally make to tell the bone marrow, make more red blood cells now. So they stimulate that process.
When do you typically start ESA therapy, and what's the goal? Is it to get hemoglobin back to normal?
Usually started when hemoglobin dips around or below 10 GDL, and this is crucial only after making sure the patient has enough iron. ESAs need iron to work. And no, the goal is not to normalize hemoglobin. That was a major lesson learned. We aim to reduce the need for blood transfusions and improve anemia symptoms like fatigue and shortness of breath.
So aiming too high for normal levels is actually risky. That seems counterintuitive.
Exactly. It's a really important clinical pearl. Pushing hemoglobin above about 11 or 11.5 GDL has been linked to increased risks cardiovascular events like hypertension, blood clots, stroke. So we aim for a target range, not full normalization. Monitoring includes checking hemoglobin frequently, blood pressure, and iron levels, ferritin, TSAT, to ensure there's enough fuel for red cell production.
Right. Okay, let's tackle potassium again, but specifically hyperkalemia when levels are dangerously high. This can be a true emergency.
Yes, and managing it involves thinking in steps. Do we need to protect the heart right now? Do we need to shift potassium temporarily? Or do we need to actually remove it from the body? Understanding these three goals is critical.
Okay, start with the most urgent, protecting the heart.
If someone has life-threatening hyperkalemia with ECG changes signs, the heart is stressed. The absolute first step is IV calcium gluconate. How does it work? It stabilizes the heart muscle cell membranes, raises their threshold potential, basically shields the heart from the high potassium's effects. Super important. Calcium does not lower the potassium level itself. It just buys you time while other treatments kick in. You watch the ECG, repeat the dose if needed.
So calcium is the shield. Then how do you actually start moving the potassium?
To shift potassium temporarily out of the blood and into cells, we use things like insulin, usually with dextrose, to prevent low blood sugar. Also albuterol, often inhaled, or sometimes IV sodium bicarbonate. These push potassium into cells quickly, but again, it's temporary. The potassium is still in the body.
Right, so for actually getting rid of it, for removing it.
For removal, we have a few options. One older one is sodium polystyrene sulfonate, or SPS. Kayexalate is a common brand name. It's a resin that works in the colon. It exchanges sodium ions for potassium ions. The potassium then gets trapped and passed out in the stool.
But I feel like I've heard some warnings about SPS limitations.
Yes, definitely. Very important points. It's slow. Takes hours to work. So not for emergencies. There's a rare but serious risk of gut injury, GI necrosis, especially if given with sorbitol, which used to be common. It can cause constipation or diarrhea. And it swaps potassium for sodium, so it adds a sodium load, which can worsen fluid retention or edema. And you absolutely don't use it if someone has a bowel obstruction or hasn't recovered bowel function after surgery.
Okay, so not ideal for urgent situations. What about newer options like patiromer?
Right, patiromer, brand name Veltassa, is one of the newer potassium binders. It's a polymer that exchanges calcium for potassium in the colon, also leads to potassium removal in stool. Onset is still relatively slow, maybe 7 hours. Peak effect takes a day or two. So again, not for emergencies. It's more for chronic hyperkalemia management, especially in CKD patients who need to stay on RAAS inhibitors like ACEs or ARBs that might raise potassium, allows them to tolerate those important meds. Side effects can include some hypomagnesemia or constipation, and like other binders, you need to separate it from other oral meds, usually by about 3 hours.
So the key lesson here is really understanding the goal: stabilize, shift, or remove, and knowing how fast each option works. That framework makes sense. Okay, kidneys don't exist in isolation, right? Meds targeting kidney issues can have broader effects. Let's explore that. Corticosteroids like prednisone, powerful drugs. What's their kidney connection? And what are those big systemic things we have to watch?
Yeah, steroids are potent anti-inflammatory and immunosuppressive agents. They work deep down at the genetic level. In nephrology, we use them for immune-mediated kidney diseases, conditions where the immune system is attacking the kidneys. Think minimal change disease, certain glomerulonephritids, interstitial nephritis.
Right. And the side effect list?
Mm-hmm.
It's notoriously long, isn't it? It affects pretty much everything.
It really is extensive. You need to be aware of potential hyperglycemia, high blood pressure, fluid retention, mood changes, insomnia, definitely increased infection risk. Also, GI bleeds, osteoporosis, muscle weakness, cataracts, and suppressing the body's own steroid production, adrenal suppression. So, monitoring is intense. Blood pressure, glucose, watching for infection. Bone protection with calcium, vitamin D, maybe bisphosphonates. And crucially, you never stop steroids abruptly if someone's been on them a while. You have to taper slowly to avoid an adrenal crisis. Very important.
Let's quickly loop back to sodium bicarbonate. We mentioned it for shifting potassium, but it has a more direct role in CKD too.
Yes, absolutely. Bicarb is a base. It buffers acid in the body. Its main renal use beyond hyperkalemia shifts is treating metabolic acidosis in CKD. When bicarbonate's levels drop, often below 22, the body gets too acidic. And interestingly, correcting that acidosis with oral bicarb might actually help slow down the progression of CKD for some people.
But even bicarb isn't totally benign. Risks involved?
Right. It contains sodium, so it can cause volume overload, edema. If you give too much, you can get metabolic alkalosis. It can cause that potassium shift into cells, leading to hypokalemia and obviously hypernatremia, high sodium. So definitely contraindicated in decompensated heart failure or significant fluid overload. Monitoring bicarbs, sodium, potassium, and volume status is essential.
Okay, what about acetylcysteine, NAC? Often hear it mentioned regarding contrast dye in kidneys.
NAC. It's an antioxidant, a precursor to glutathione, and it breaks down mucus. Historically, it got a lot of attention for potentially preventing contrast-induced AKI kidney damage from IV contrast dye used in scans. However, the evidence for that is, well, pretty weak and mixed now. Lots of debate. You still see it used sometimes because it's generally low risk. But the real key clinical pearl here, the most important thing to prevent contrast AKI is IV fluids, usually isotonic saline. If NAC is used, it must be alongside fluids. Its main proven use is actually as an antidote for acetaminophen overdose.
Got it. Lastly, let's touch on eye drops. Seems minor, but can they have systemic effects relevant to CKD? Beta blocker drops, for example. How can an eye drop affect the whole system?
It's a perfect example of interconnectedness. Beta blocker eye drops like timolol lower eye pressure by reducing fluid production in the eye. But some of the drug gets absorbed systemically, often through the nasal passages after draining from the eye. For someone with CKD, especially if they're older or already on heart meds, the systemic absorption could potentially worsen a slow heart rate bradycardia or lower blood pressure further. No specific dose change needed for kidney function, but you monitor blood pressure and heart rate carefully.
So even an eye drop isn't just an eye drop. Good point.
Exactly. And a useful tip for patients: teach them punctal occlusion. Gently press the inner corner of the eye for a minute or two after putting in the drop. Blocks the drainage duct, reduces systemic absorption. On the other hand, another class, prostaglandin analogs like latanoprost, they lower eye pressure differently by increasing outflow. They generally have very minimal systemic effects, considered quite safe in CKD. Their side effects are mostly local iris darkening, longer eyelashes, skin darkening around the eye, usually permanent but benign.
Wow. Okay, that was a truly deep dive. We've covered diuretics, mineral balance, anemia, the whole potassium tightrope, and even eye drops.
It really highlights how understanding the mechanism, lets you see the bigger picture, right? Connect the dots in complex situations, appreciate the body's balance. That's where knowledge becomes powerful.
So for you listening, what's the takeaway? Next time kidney health or these meds come up, you'll have these insights, these frameworks. You'll understand things on a deeper level. And think about this. We saw how drugs for one system ripple outwards. It makes you wonder, what other specialized treatments might have unexpected widespread effects across the body that we maybe overlook? Something to mull over until next time. Thanks for joining us on this journey. Stay curious, stay informed. We'll catch you next time for another deep dive.